You good?
Good afternoon or good morning, everybody, and thank you very much for inviting us here today to tell you about some work we've been doing around palliative care and homelessness. My name is Dr. Bryony Hudson. I am the Associate Director for Internal Research Development at Marie Curie and Honorary Research Fellow at University College London. So I'm here today with my colleague Jodie Crooks, who also works at Marie Curie as our Qualitative Research Manager, to tell you about some research that we've been doing sort of as a collective for a couple of years, but focusing specifically on involvement in palliative care research for people with lived experience of homelessness. And before I get started, I just want to thank our collaborators, so Gareth Davis, Dr. Caroline Schulman, and Professor Kate Fleming. So the paper that you've invited us here to speak about today is here on the slide, and that is a study titled Involving People with Lived Experience of Homelessness in Palliative and End-of-Life Care Research, Key Considerations from Experts in the Field. And this study stemmed from a grant that we were awarded in 2022 from the National Institute for Health and Social Care Research in the UK, which focused really on creating professional networks. So people from lots of different professional backgrounds with an interest in palliative care for people with lived experience of homelessness. And the grant aimed to bring people together in sort of an online forum to learn from each other and share experiences. And in kind of linked to that, we did a separate qualitative study looking at how best can we involve people with lived experience in palliative and end-of-life care research, because currently there wasn't really any guidance about how best to do that or what the key considerations for doing that might be. So the paper that we're going to talk about today outlines those key considerations that we heard about and that we learnt about through interviewing staff and people with lived experience of homelessness to get their views on what is important to consider. So before we get into the paper, I thought it might be helpful just to give you a bit of context and a bit of background about homelessness and health and homelessness and palliative care. So homelessness is a complex social and political issue that affects families, individuals and communities worldwide. The term homelessness itself encompasses a wide range of situations, but in all of its forms, being homeless is associated with a lack of safety, security, privacy and stability. People affected by homelessness experience some of the worst health outcomes in society. They face many barriers in accessing services, and they often die in unsupported and undignified situations. In the UK, there's been some work led by the Museum of Homelessness called the Dying Homeless Project, which documents the number of deaths among people experiencing homelessness. And their latest report shows a 12% increase in the number of deaths in the last year alone, a staggering total of 1,474 deaths. And further statistics that paint a fairly bleak picture of health and homelessness come from the Office of National Statistics in the UK, which places the mean age of death for people experiencing homelessness at 45 for men and 43 for women. So we know the health of people experiencing homelessness is often poor, and we know that people are often dying at a very young age, but what do we know about access to palliative care? Well, we know from both UK and international literature that this is a group of people who rarely access palliative care, and they often die without adequate support. And this is for a range of reasons that are interrelated and fairly complicated. But really the first challenge to palliative care access for this group centres around a lack of identification. So we've seen that this group of people don't fit the usual profile of palliative care patients. They're often very young and have potentially treatable conditions. So sometimes there's a challenge about referral to palliative care services and thinking about when that's appropriate and when that should be introduced. And research that we've done, and also research from Canada, has highlighted uncertainty from both staff in medical and homelessness services about who could be considered palliative, when palliative care planning should be introduced, and what that might look like. Issues around place of care and fitting into services that are generally catering for a mainstream population lead to a lack of referrals to palliative care services. And in the UK, a lot of people experiencing homelessness reside in hostels or temporary accommodation, and many of these services, understandably, operate under an ethos of recovery. So their focus is to help people move to less supported accommodation and eventually away from homelessness. And hostels and temporary accommodation providers aren't designed to provide support for people with advanced ill health, and the staff in these settings aren't medically trained, because why would they be? They didn't go into this role for that purpose. Yet because of the lack of choices in place of care, a lot of people working in hostels are having to do this. So they're doing the absolute best that they can in really difficult situations and often feel quite isolated and unsupported by the services that they're trying to engage. So that's a really brief summary of some of the challenges to palliative care access that we've seen from our own and from others' research, and what we think might help to shift the dial and improve access to this group. Focus really around shifting that focus. So currently the difficulty in identifying when someone could be considered palliative is a major stumbling block to action. And moving the focus of care and support and consideration about palliative care away from death and dying and more towards support for people with advanced ill health has the potential to really improve person-centred care, promote dignity and well-being in this context, and unlock access to services that could be of real benefit. So this is a form of hoping for the best but planning for the worst, and it could enable the introduction of discussions and planning much earlier in people's illness trajectories to try and enable supports to be available and ready for people if and when they might need them. Secondly, there's a really clear need for multi-agency collaboration and recognising the different forms of expertise among different people. And linked to a shift in focus, a broad approach to palliative care and an inclusive approach to palliative care could help to account for the marginalisation and trauma that people have experienced and be really, really impactful. And that's what we were hoping and aiming to do with our previous NAHR grant, is bringing people together. And in the UK, there have been some really good examples of where regular multidisciplinary team meetings are happening, which are transforming the care people experiencing homelessness are able to access and the quality of life that they have toward the end of life, both for themselves and for people that are looking after them. But ultimately, what we think would really improve experiences is choice. And that's choice for people about how care they received is delivered and where that care is delivered. So that hopefully was some useful context for the discussion that we'll have today. And what we were looking at in the paper that we've been asked to talk about was co-production. And how can we bring co-production into research in this field with this population? So first of all, what is co-production? It is research, co-production and research aims to involve the target audience for its intended outcomes in the conceptualisation, delivery and dissemination of research. It aims to integrate the unique knowledge of people with lived experience in substantial and meaningful ways to create impactful research that's informed by real life experiences. So it's different from being a participant. It's very much about being integral to the design, the dissemination and the delivery of the project. And we know recently that some co-production of palliative care research has increased, and there's also been some co-production of research with people experiencing homelessness. But critically, the overlap between these two areas has not yet been fully explored, and that was the gap that we were trying to fill with this project and with the Tiffin recommendations that Jodie will talk about shortly. So why do we need to do this? What's the point? Why do we need this guidance? Well, we've seen that experiences of trauma and exposure to death for people experiencing homelessness can contribute to sensitivity in discussing palliative care and dying. So we need to understand, what are the barriers? What do people think about talking about death and dying? And how can we create an approach that is trauma-informed and as accessible for people as possible? And it's essential that any involvement in research in this area is safe, supported and prioritises wellbeing. So with that, I will hand over to Jodie to talk through the methods and the findings from that paper and the Tiffin recommendations.
Thank you, Bryony. Okay, so the aim of this research in this paper that we're discussing today was to identify key context considerations for involving people with lived experience of homelessness in palliative and end-of-life care research. So it was a qualitative study. This paper was actually formed part of a larger qualitative study with an associated paper that I'll discuss on the next slide in case that's of interest. But the data collection was in two main streams. First, we did interviews, and that was with professionals with experience of involving people with experience of homelessness in their work, whether that was research, projects, policy work. And then we did focus groups with 10 people with lived experience of homelessness. And we used iterative, reflexive thematic analysis to analyse the data and come up with the themes that I'll chat through in a second. So, as we mentioned, the paper we're discussing at this meeting today is part of and uses the same qualitative data as this second paper. That's titled Development of the Tiffin Recommendations for Co-producing Palliative and End-of-Life Care Research with Individuals with Lived Experience of Homelessness, and is linked through the QR code on there in case you're interested in reading further. I won't go into loads of details here, as we're not here to talk about Tiffin specifically, but I do think it's important to acknowledge that all of the context considerations and the themes that I'm about to discuss stem from the same data as these Tiffin recommendations. And so the themes behind our recommendations that make this lovely acronym of TIFIN are transparency, importance of engagement and report, facilitating equitable involvement via a person-centered approach, financial recognition of people's involvement and growth through a trauma-informed approach, and navigating institutional resistance and attitudes. So they're sort of the 6 themes that underlie our recommendations for how best to approach involvement in this field of palliative care and homelessness. But onto the actual themes from the paper we're discussing today. We found 4 main themes that considered the context in which involvement of people with lived experience of homelessness in palliative and end-of-life care research should be considered. The first theme explores the complexity of lived experience of homelessness. So participants spoke about the fact that homelessness in the modern day is really complex, as Bryony touched on earlier. There are many different types of homelessness, including those that are quite hidden, like sofa surfing or staying at a friend's house longer term, that we have to zoom really far out to see the full picture of homelessness. Participants recognised that we need to move beyond traditional interpretations of homelessness that might be focused on rough sleeping or hostel accommodation when recruiting people with lived experience to take part in palliative and end-of-life care research. And that's indicated quite nicely on that theme quote on the left, sorry. On top of that, each person who experiences homelessness has such a unique experience that's different to the next. So this heterogeneity can become even more pronounced when we consider experiences of advanced ill health too. So participants spoke about how each co-producer or how each person with lived experience involved in a project brings a really valuable and unique experience to that research. Because of this diversity and experience, professional participants said that they rarely used a formal definition of homelessness as eligibility criteria for lived experience for who gets to be involved in their research, because they said it felt too reductionist and like they were assigning labels to people. Instead, people often allowed the co-producers to self-define their homelessness. However, people did discuss that difficulties sometimes arose where individuals didn't explicitly or openly identify as having experienced homelessness. So a definite space for thought then comes with asking people to self-define their experience and whether this is asking them to just put those labels on themselves or face different stigmas that might be associated with their experience. Furthermore, participants, can we go back a slide? I've got one more point. Thank you. Furthermore, the participants reflected that experiences of a phenomena can be both past and present. So you can have both living and lived experience in a way, and it's likely that individuals involved in research may sit along a spectrum of homelessness experiences and involvement experiences, like that quote on the right there says. Thanks, Bryony. So the second theme is how homelessness is represented within experts by experience. So professionals reflected that it was quite common when involving people in research to select someone who presents well or who will fit our narrative, as that first quote says. Participants discussed how there can be a degree of capability bias in selecting individuals to be involved in research, and that they were aware of their own or others' tendency to select individuals who hold particular skills or traits that might make them better equipped to engage in research involvement. And though this selective practice may be seen as othering, they did express that it can be difficult to safely represent people who are experiencing homelessness in their current lives, who might be in chaotic positions currently. And this kind of came through from the focus groups with people with lived experience as well, through that quote on the right. They said that in order to feel able to be involved in research for them, they felt they had to have experienced some degree of recovery or progression through their journey to be in a place where they could engage with involvement opportunities. Thanks. Okay, so the third theme was how lived experience can become professionalized throughout involvement. So we've discussed the sort of spectrum on which an individual's experiences may lie. And by that, I mean, with each time that somebody is involved in research, their experience becomes more layered. So people may begin to have lived experience of homelessness or the phenomena under research and lived experience of carrying out research, policy or practice work, whatever the co-production is. So participants suggested that this can create a group of people with lived experience of homelessness who transition from sort of from lived experience into becoming consultants about lived experience and how we are professionalizing that in a way. There was discussion about how this overlap of lived experiences can create a range of pure lived experience to pure academic experience that can be considered throughout the projects. And sometimes people felt a pressure to use that lived experience. I don't know if use is the correct word there, but if people feel expected or pressured to become involved in research because of their experience, then that might not be the best way to approach things there. And that quote at the bottom just says, I don't think there's any clause that says, now you have experiences, you must use this wisely. And then the final theme is the methods for involvement. So this is a little bit more practical. But participants, so both professionals and people with lived experience of homelessness, reported involvement in a range of different research activities. There was a distinction drawn between like involvement in research that was legitimate co-production versus simple consultation that's more like traditionally PPI based. Examples of areas of involvement included collaboration on research question formulation, being co-applicants on grants, data collection, such as co-interviewing, involvement in policy recommendation development, and feedback to services to aid further development. A critical part of involvement reported by professionals was involving people with lived experience as early as possible in the process to avoid making mistakes or having oversights in the design of the research, and to allow the researchers to see the topic of their research from a different perspective. And this was also reflected by the people with lived experience of homelessness in the focus groups, who appreciated the opportunity for early involvement and recognised that they'd been involved in projects in the past where they felt they were introduced too late and they had to change things, or they had to give more difficult feedback on a project that a researcher had already started on. So that's all for the themes. To summarise that into a few take-home messages, first of all, I would definitely recommend also reading the Tiffin paper, because the recommendations in there are linked really closely to those themes I just discussed, and I think are really good food for thought for co-production in this field too. But essentially, it's important to include people with lived experience of homelessness in the design, conduct, and dissemination of research in palliative and end-of-life care. However, it does really need to be done in a trauma-informed way, as Bryony outlined at the start. There's no one-size-fits-all approach to doing this. It needs to be flexible. It might not be a traditional research method or project as you have experienced in the past or you've envisaged. Things will change week by week. And most of all, keeping the best interest of the individual, the person with lived experience, at the centre of the work is really critical to promote their involvement being ethical and safe and considered. And I've just put the Tiffin themes at the bottom there again. I'll very quickly chat through the next steps. So following on from this piece of work and the Tiffin recommendations, we have carried out a small qualitative study that's explored the idea of death cafes for people experiencing homelessness. And as part of that, we worked with a lived experience co-researcher who did half a day a week, so 10% full-time equivalent, to support with all elements of the research. Throughout that, we've collected reflective diaries from ourselves, from them, from the organisation supporting them, to sort of summarise our key learnings and hopefully pass these learnings of co-production in this field on to other people wanting to do similar projects, and also amend the Tiffin recommendations if needed. And we've also applied for funding, to be confirmed, to transform those Tiffin recommendations into a guidebook that's really accessible to people experiencing homelessness who might be interested in getting involved in palliative care research, to sort of accelerate the impact of this involvement exploration that we've been doing. Thank you so much for having us today, and I'm sorry that we can't be there live. I hope you have a lovely discussion following this.